Very good evening. Today we'll be having a class on classification and clinical characteristics of gingival and periodontal diseases. So coming on to the learning outcomes, from this class we would like you to point out the need for classification, outline the classification of gingival and periodontal diseases based on 2017 classification, and differentiate the diagnostic features of healthy and gingiva and diseased gingiva. Our understanding of the etiology and pathogenesis of periodontal diseases is continually changing with increasing scientific knowledge. Any attempt to group the entire constellation of the periodontal disease into an orderly and widely accepted classification system is fraught with difficult and considerable controversy. So there is always a need for classification. So why is this required? It allows for a logical and systematic separation and organization of knowledge about the diseases. It could allow for a direct research, thereby we could learn more about the diseases which are a main concern. It guides the practitioners for finding the best method for treating a disease, plan treatment protocols to maximize the benefits to all their patients, basically to make it an evidence-based treatment protocol. It enables the international community to communicate in a common language and guide the public health planning and result in better treatment perspectives. So basically, when a patient comes to you, there would be signs which are seen by you, symptoms which are told by the patient. So you should try to reason out from the signs and symptoms. Try to reason out from the signs and symptoms of the patient, and then go in for a presumed history. Ask the patient's history, go in for a presumed etiologic history, then go in for the identification of the condition, and then prescribe a course of the treatment. So initially there were certain groups which went in for classification, wherein they found that the clinical initially the classification was based on the clinical conditions of the patient. Like for example, if there was bleeding gums, they would say it is gingivitis. So it is initially they found the clinical characteristics of the patient and they classified it accordingly. But later they found out that there was some pathology which is underlying in them. Pathology in the sense there is some bacterial action which is going on, some pathological lesions which are occurring in the gingival diseases, and therefore the disease status occurs and it has to be classified accordingly. So from 1920 to 1970, the diseases were classified based on the pathology. But now it has been little different, wherein the authors found out that there is a difference, there is an interaction between the infection as well as the host. So the present classifications are based on the infection host response. So that is the present classification which we follow right now. So in the last 130 years, many classification systems for periodontal diseases have been used. So you can see the number of classification systems, but till recently, we had the American Academy of Periodontology classification system 99, which was used to identify distinct types of periodontal diseases, and they came out with the two major categories of diseases termed as gingivitis and periodontitis. So you can see the 1999 classification. I'm just giving a broad view of this because this we have been using it till your previous seniors batches, but now we have a different system of classification. So this all belongs to your old classification, the 99 classification. So in 99 classification, you do have a set of 7 periodontal diseases, but there were certain limitations of 99 classification, wherein they couldn't give a proper case definition for periodontal health, they couldn't give a proper case definition for gingivitis, the definition for the localized and generalized form of disease was not defined, a limitation on the evidence of a term called as aggressive periodontitis, that is a disease called aggressive periodontitis. They didn't have proper evidence. Peri-implant health and diseases were not dealt with in the previous classification. Risk factors were not included as a major criteria for diagnosing or classifying the disease. So because of all this, 99 classification was considered to be a little not as a failure, but it was considered a little lower than the present classification. So the periodontist came up with the classification in the year 2017. So it is very near, you can just imagine where 2017 is. So last 4 or 5 years we all followed this classification, wherein periodontal diseases have been classified as the periodontal It has been classified as periodontal health, gingival diseases and conditions. The second one as periodontitis. The third one as other conditions affecting the periodontium, and the fourth one as peri-implant diseases and conditions. So we will go on to tell what exactly happens, what is gingivitis, what is periodontitis. So initially the patient, if he is left to, if he has not properly brushed, or if he has left brushing, or if he has not properly taken care of his gingival health, what happens is that the status from the periodontal health goes into the next stage of disease known as your gingivitis. So even at this status, if the patient is not going to clearly remove out his deposits, then it goes to the third stage of condition known as the periodontitis. So if the patient is given some proper periodontal therapy, then the patient tends to revert back to a patient with a good gingival or periodontal health. But if he is not going to come back to his normal position, or if he is not going to maintain it well, then he goes into this red zone criteria, wherein the periodontitis patient is there with an uncontrollable or unstable case of recurrent periodontitis. So in the pictures you can see that when the patient has not clean his teeth properly, then you would get the first stage of disease known as gingivitis. So even if this at this position, if the patient is not approached a dentist, then he lands up in the next conditions, wherein there is loss of bone, loss of clinical attachment, loss is there, resulting in periodontitis. So early and moderate, it's fine, but advanced periodontitis, then obviously the next step is going to be extraction in those cases. So coming on to the classification of periodontal health, gingival disease and condition. So this is the first classification. So I have told you that there are 4 classifications. First is your periodontal health, gingival diseases and condition. Second is your periodontitis. Third is your other conditions affecting the periodontium. Fourth is the periodontal implant and periodontal health. So this was there in the previous slide. So now onwards we will be speaking on classification of periodontal health, gingival disease and condition. So what is gingival health, or what is periodontal health? So if a patient comes to you when he is in a state or free from any inflammatory periodontal disease, then you would categorize such a patient as a gingivally healthy patient. In short terms, if you follow the flow chart which is given here, clinical gingival health, if it occurs in the intact periodontium, we give the diagnosis as gingival health or good periodontal health. If it occurs on a reduced periodontium, we give the diagnosis based on a diagnosis of clinical gingival health on reduced periodontium. This could be because of a non-periodontitis condition, or it could be because of a stable periodontitis condition, wherein the patient who is got a periodontitis has gone into a healthy status. So the second classification includes your gingivitis. Gingivitis, it is the clinical signs and symptoms of the inflammation that are confined to the free and attached gingiva and does not extend beyond the mucogingival junction, which means gingivitis is confined only to the free and the attached gingivitis. So here you have 2 kinds of classification. One is dental biofilm induced, that is plaque induced. Another is non-dental biofilm induced, that is non-plaque induced. So plaque induced could be because of the non-periodontitis, or it could be because of the stable periodontitis. So coming on to the classifications in major, pristine clinical health. So what is this condition called as? Pristine clinical health is obviously you couldn't see all patients with such a condition where there is no attachment loss, no bleeding on probing, no cellular depth, no redness, no clinical swelling, edema or pus. So obviously this is considered exceptional and is largely limited only to the textbook. Only 5% of the population will have such a beautiful set of arch, whereas we all would follow, or most of the patients would be on this status, wherein you give the diagnosis as clinical gingival health for an intact periodontium or a reduced stable periodontium, where clinical gingival health is defined as minimal bleeding on probing less than 10% of the sites, probing pocket depth less than 3 mm, no probing attachment loss or radiological bone loss. So if you see these 3 conditions in a patient, then you term the patient to be a clinically gingival healthy patient. Okay, so this clinically gingival healthy patient, healthy status can exist at a site level, or it could exist at an overall mouth level. It could exist at an intact periodontium, or it could exist at a reduced periodontium. So first of all, we will see in an intact periodontium. So clinical gingival health is an intact periodontium is the same as above as I told you, just that there is no clinical attachment loss or bone loss. Bleeding on probing is less than 10%, pocket depth is less than 3 mm. Whereas clinical gingival health on a reduced periodontium. So this is a tricky term, which means that the patient is a non-periodontitis patient. Here you could see in the diagram, you could see a case where there is gingival recession, but this is because of cervical abrasion resulted from abnormal brushing habits. You can see the picture there. Abnormal brushing habits resulted in the gingival recession. So such a case, if it is going to have bleeding on probing less than 10% of sites and probing depth less than 3 mm, then they would fall into the category of clinical gingival health on a reduced periodontium. Whereas on the other hand, you can see the picture down here, the gingival healthy status is maintained in this patient, but this patient had a history of periodontitis who is now currently in a stable state. So always remember that if the patient is found as a periodontitis patient, remains a periodontitis patient for the rest of his life. Increased risk for recurrent periodontitis and is to be closely monitored. Here, generally the bleeding on probing is less than 10% of the sites and probing depth is less than 4 mm. So gingivitis, the second classification, wherein dental biofilm induced. So it is a stage of periodontal inflammation confined to the gingival tissues and related to the dental biofilm, otherwise the plaque. Gingivitis case definition in an intact periodontium. So if it is going to be a localized gingivitis, then you would be having no attachment loss, no radiographic bone loss, less than 3 mm of probing pocket depth, 10 to 30% of bleeding on probing. So remember that if it is going to be less than 10%, then it is clinical health. If it is 10 to 30%, then it is localized gingivitis. If it is more than 30% of bleeding on probing, then it is a generalized gingivitis. So again here you have gingivitis on a reduced periodontium without history of periodontitis. So as I told earlier, here there could be some amount of attachment loss present, some amount of radiographic bone loss present, but it will not be having a drastic change in the supporting structures. Localized, it is considered to be localized if it is 10 to 30%, generalized if it is more than 30%. So next category, gingival diseases, non-dental biofilm induced. So this is a state of gingival diseases wherein it is induced by non-plaque induced pathological lesions limited to the gingival tissues. Although these lesions are not directly caused by the plaque, their clinical course may be impacted by the plaque accumulation and subsequent gingival inflammation. So this could be, so if it is by non-plaque induced pathological lesion. So what are the causes for this? It could be hereditary, or it could be specific infection, for example bacterial, viral or fungal. It could be because of any inflammatory or immune conditions and lesions, reactive processes, endocrine, nutritional, metabolic diseases, any traumatic lesions or gingival pigmentation. So all this, if it results in any changes in the gingiva, then it is tend to be a gingivitis due to a non-biofilm induced condition. The second classification, periodontitis and other periodontium, other conditions affecting the periodontium. So you have a set of classification for the two of them. I have put forward in this slide for you. Go through this. So we'll go on first with the basic periodontal examination. So any patient who steps into your clinic, and if you want to see for their periodontal health, you need to go for this particular examination called the basic periodontal examination, called the BPE, wherein this is a simple and a rapid screening tool that is used to indicate the level of further examination needed and provides basic guidance on the treatment needed. So here you can see a picture wherein there is a probe present. So this probe is the WHO probe. This probe would be given to you while you come to the clinics to see your patients. So you could see a ball of around 0.5 mm in the bottom. There's a black marking of around 3. The shaded marking denotes your black marking, around 3.5 to 5.5. So tomorrow when you go to the clinic, just check out the probe which is given to you. You will be able to see the ball as well as the markings which are present there. So based on this, we do have certain criteria or scoring codes, how it is being transferred to the papers, how disease is being transferred in terms of letters to the papers. So when the patient comes and when you're going to start your BP index, you're going to divide the entire set or dentition into six sextants starting from 17 to 14. Your tooth number 13 to 23, 24 to 27, 34 to 37, 43 to 33, and 47 to 44. So after analyzing, supposing with the probe you are analyzing the area tooth number 17 to 14, and if you find that there are no pockets, no pockets less than 3.5 mm, no calculus or overhangings, or no bleeding on probing present, then it falls under the category 0. If there are less than 3.5 mm pockets, no calculus or overhangings, but bleeding on probing is present, then your scoring code for that sextant is 1 mm. Pockets less than 3 mm, 3.5 mm, supra and subgingival calculus and overhangs present, your scoring criteria is 2 mm. So if the pockets probing depth is 3.5 to 5.5, so you will be able to see this if the black band of the probe is partially visible, indicating the pocket of 4 to 5 mm. Probing depth of more than 5.5 mm, where the black band disappears, indicating a pocket of 6 mm or more. So based on this, you do have the BPE calculation, like for each sextant we have written. So 1714, tooth number 17 to 14, according to the BPE calculation, it has 1, which means the scoring code pocket depth is less than 3.5 mm. There's no calculus overhangs, bleeding on probing is present. So accordingly, you do have the treatment guideline also for the BPE scores. So go through this charting. This is very important. So coming on to the clinical characteristics of the gingival and periodontal disease. So as you all know, I think we have already had a class on clinical features of gingiva, and we've already had a healthy periodontium class 2. So a Google Meet lecture also was given for you based on the clinical features of gingiva. Just go through all of them and just read this slide once more. So gingivitis. So how would generally, by definition, it is inflammation of the gingiva in the absence of the clinical attachment loss. So how would you what would the patient say if he has gingivitis? So the patient would come with bleeding gums, deposits between the teeth, swelling of the gums, there could be a color change in the teeth. So this is all the patient's complaint. So what would you examine? So when you see the patient, you could see some reddish discoloration of the gingiva, or there could be a reddish bluish discoloration. Soft and edematous, firm and fibrotic area could also be present. Bleeding on probing, this is an absolute yes category. If it is present, then it means that gingivitis is present in that patient. Presence of local factors, enlarged interdental papilla. So all these are related to gingivitis. So there was a study done by Lowe wherein he asked the patient not to brush for 21 days, and he found that there were certain changes which were taking place in the gums. So accordingly, he has staged them as initial lesion, early lesion, and established lesion. This was put forward by Page and Schroeder. So initial lesion, that is once the food deposit is left out without taking, that is the first 2 to 4 days. If your acquired pellicle is not removed properly, then it results in the plaque formation, wherein blood vessels, vascular dilatation, vasculitis is there. Neutrophils, the first line of defense, comes into play with loss of collagen and gingival fluid flow being high. The second lesion occurs from 4 to 7 days, wherein there is vascular proliferation with red apex atrophic areas. The predominant cell here is lymphocytes with increased loss of around the infiltrate, erythema, and bleeding on probing is present. The third stage is your established stage, wherein there is 14 to 21 days. Stage 2 plus blood stasis is present in this condition. There is more advanced red apex or atrophic areas. The predominant cell here is plasma cells. There is continued loss, change in color, texture, and size. So this you would notice if your patient is progressing in his disease. So try not to make the progress occur, but try to intervene at the very initial lesion itself. So here's the condition of periodontitis. So as I explained before, periodontitis it is an inflammatory disease of supporting tissues of the teeth caused by specific microorganisms or groups of specific microorganisms, resulting in progressive destruction of the periodontal ligament and the alveolar bone with pocket formation, recession or both. So again, to tell on this definition, you will be learning more about this in classes to come. So you will be familiar what this definition is, why have they defined it, just instead of telling just inflammation of the periodontium, why is such big what is being there in the definition. So you will eventually come to know about it, right? So how do you diagnose a periodontitis case? So if there is a interdental clinical attachment loss present between two teeth, and if there is the buccal attachment level is more than 3 mm, with pocketing of more than 3 mm is detectable at two side teeth. If this is the condition, then we tell it to be a periodontitis. But the observed clinical attachment level cannot be ascribed to non-periodontal causes such as GR, gingival recession of traumatic origin, dental caries. You can see the diagrams below, so I am telling it according to that. Dental caries or the presence of clinical attachment loss on the distal aspect of the second molar and associated malposition or extraction of the third molar, an endodontic lesion draining through the marginal periodontium, the occurrence of a periodontal root fracture. And as I told you, if it is less than 30% of the teeth involved, we classify them as localized. More than 30%, we classify them as general. Next, coming on to the grading. So the grading is based on the indirect evidence of progression, wherein if there is going to be a heavy biofilm deposits with low levels of destruction, you put them under slow rate of progression. Destruction commensurates with the biofilm deposits, grade B. But if the destruction exceeds the expectations given by biofilm deposits, we put them as grade C. So this classification has included the risk factors also into account. So grade A includes non-smokers, grade B smoking less than 10 cigarettes, grade 3 more than 10 cigarettes, and grade A again if there is normal glycemic or no diagnosis of diabetes. HbA1c less than 7% comes under the grade B category. Of HbA1c more than 7% comes under the grade C category. So all the others are still in the study phase. All the other factors, biomarkers and everything is in the study. So what are the symptoms of periodontitis condition? So the patient might come with you telling about their deposits, stains, dull localized pain, spacing, drifting of the teeth, pus discharge, bad breath, food lodgement, mobile teeth, difficulty in mastication, difficulty in speech. So any of these following conditions, examine the mouth. If there is attachment loss, then means that the patient is having a periodontitis condition. So here you can see the 5 to 9. So all this, if it's going to be present in the patient, then you're going to tell that the patient is going to have attachment loss, and because of that it is periodontitis. So color change, loss of contour, stippling, change in consistency, probing pocket depth, mobility, recession, percussion involvement, bone loss, malaligned teeth, tender on lateral percussion, and pus discharge. So I've given you another wording by the side, wherein if you want the patient to be told as periodontitis, not only that the interdental clinical attachment loss should be more than 3 mm, but also if you have any pockets, mobility, recession or percussion, then that exactly falls into the category of periodontitis. So to conclude, as classification systems have evolved, newer thoughts about periodontal disease have been superimposed on a matrix of older ideas that are still considered to be valid. One of the interesting historical features of classification systems is often the intense resistance to their modification. However, classification systems should be viewed as a dynamic work in progress that needs to be periodically modified based on current thinking and knowledge. Thank you. For further doubts, please do contact the Department of Periodontology.